All right, I think we can start. Good morning, good afternoon, and good evening, everyone. Welcome to this Asia PGI webinar on emerging fungal STIs in Asia, where we're going to look at clinical surveillance and public health perspective on TM5 or Trichophyton mentagrophytes genotype 7. This is an emerging, highly infectious fungal infection, primarily transmitted through sexual contact. I am Miruna Rosu, and I'm a senior research fellow at the Center for Outbreak Preparedness at Duke-NUS in Singapore, and I lead the Asia PGI Academy. Just a brief introduction of the Asia PGI. So here we really strive to prepare the Asian region for future outbreaks and to enhance pathogen genomic capacity and capability through different activities such as training and capacity building via the academy, but also strategic design of cost-effectiveness systems, governance, and development of tools, AI-enabling tools in the genomics space, but not only. So without further ado, let me introduce the speakers we have joining us today. We have four speakers lined up from three different countries. We have the US, Thailand, and Vietnam. So from the US, we have Dr. Irina Kasarskis, who's joining us from US CDC within the mycotic disease branch, and Dr. Tom Carpino from the Duke University Global Health Institute. From Vietnam, we have Dr. Thuy from the Tropical Medicine Research Center for Talaromycosis, who I'm hoping is already online, and if not, will be joining us shortly. And from Thailand, we have Dr. Rossaphorn Kittiyaowamarn from the Department of Disease Control, Ministry of Health. So we will start with Irina, then go on to Dr. Thuy, Dr. Rosenhorn, and Dr. Tom. So before I allow Dr. Irina to start her presentation, I would like to give a very brief housekeeping message. So do please introduce yourselves in the chat. I would love to hear where you're joining from. And also try to keep as much as possible the questions in the Q&A section, which you can find if you click on this three dots, mention more. At the end of the presentations, we're going to go and have a 10 to 15 minutes discussion with the help of your questions. So without further ado, please, Irina, the floor is yours.
Great. Thank you so much for having me. Let me just get my presentation going, confirming that you can see everything
All is good.
correctly. All right, perfect. Thank you guys so much for having me. Today I'll be giving a brief introduction to Trichophyton mentagrophytes, genotype 7. Throughout the rest of my presentation, I'll simply just say TM7. So let's start, before we kind of get into the weeds, let's start back and talk just about what dermatophytosis is. It's frequently known as tinea or ringworm, and this represents a contagious fungal infection that can affect both the skin of human and animals. We often think of it as a mild and treatable infection with over-the-counter topical antifungal medication, and when lesions show up, they're typically found on the trunk and extremities, the scalp, feet, and groin. So ringworm can be transmitted in two main pathways. The first is through direct contact. So we like to think about skin-to-skin contact with either an infected animal or human, or through indirect contact with a contaminated surface like a towel or other environment. So why do we actually think that TM7 is notable and really different from a standard or classic ringworm infection? So TM7 often presents as a severe inflammatory disease. It can be painful, persistent lesions that have the risk of scarring or secondary bacterial infection. When it shows up, the lesions are typically on the genital or perigenital skin, and this really differs from a more traditional ringworm infection where there can be lesions that show up in the groin, but they don't usually actually show up on the genitals themselves. So TM7 is frequently mistaken for other bacterial sexually transmitted infections or skin conditions due to its inflammatory appearance and the location on the genitals. It can be really difficult to diagnose these infections for a couple of reasons. The first is that many patients, when they show up to a provider for diagnosis, have already completed a course of either topical steroids or topical antibiotics. After those treatments, that can kind of modify the rash that's showing up, and so it might not catch the exact same appearance as like the classic dermatophytosis. And then finally, our patients, when they do show up, they're often subjected to a prolonged treatment course. So, treatment typically involves a systemic antifungal therapy for about 1 to 2 months. It really depends on the patient, and it can sometimes last longer. Importantly, patients can't usually use a topical antifungal therapy because the lesions appear in areas where there are hair, and that medication can't actually penetrate through the hair follicle. So I want to kind of go back in time as to when we thought and started thinking that dermatophytosis might be spread through direct skin-to-skin contact between humans through intimate or sexual contact. And so some of the earliest times we heard about this in the literature was back in 2002 when Otero and colleagues hypothesized when they saw a case series of 7 female sex workers that sexual transmission might be a thing. There was another group at the same time that started to notice among female sex workers in Nigeria that they were starting to see a lot more increases in dermatophytosis in that population. As we move forward in time, in 2014, we saw the first reported sexually transmitted TM7 cases coming out of Zurich, Switzerland. And the patients reported in this cluster all reported initial lesions in the genital area, and many of them also reported shaving in that same area where the skin barrier was disrupted and likely supported transmission of TM7. Importantly, 3 of the cases in this cluster had reported recent travel to Southeast Asia where they had sexual contact, including contact with sex workers. From 2016 to 2017, we saw that there were 37 suspected sexually transmitted TM7 cases in Berlin, Germany. This occurred in both male and female patients, and only 4 of those patients reported recent travel. So it started opening up the idea that sexual transmission might be happening in local transmission within Europe. So as we fast forward in our timeline, since 2021, both France and Germany have reported over 20 cases of sexually transmitted TM7, whereas Spain, Italy, Greece, and the United Kingdom reported fewer than cases. And we really started to see a change in the demographic of the patients who were being diagnosed with TM7. So we really started to see that 98% of patients in this era were men, and when we had data available, the majority said that they were men who had sex with other men. The majority also did not report any recent travel history. And so when we look at our molecular epidemiology, the more recent strains that were coming out of both France and Switzerland were really starting to show differences from what we've seen from infections that were reported out of Southeast Asia. So on the next slides, I'm going to give you some pictures of the lesions of TM7. So I just want to alert you that there are some pictures of the genital area. So as we move forward in Europe from 2022 to 2023, we saw a really interesting cluster that happened. And this was a cluster of 16 cases that were all linked back to an index patient who was a tantric masseur. And what we learned from this cluster is after any session by this individual, the linens were changed after each patient. They were washed at a high temperature. Both the client and the masseur had full body skin-to-skin contact during a session. And he started to develop over 10 lesions on April 15th, 2023. He continued providing massages to 19 other individuals until April 27th, 2023, and 18 of those clients developed similar lesions. And what's really interesting is that 4 of the clients who were seen before April 15th, the date of symptom onset, they also started showing lesions. This individual, the index patient, had a roommate where they didn't have any skin-to-skin contact, but they did occasionally share bathroom linens. And the roommate started showing a single lesion on his back. So this paper kind of highlights some of the key features that we were interested in. There's the potential for pre-symptomatic transmission and superspreading of TM7. So on the right side of the screen, you see pictures of some of the patients that were reported in this cluster. And I really want to focus that none of these lesions are showing up in the exact same region of the body, and they don't look exactly identical. So there's a variety of different presentations. The same group also provided another paper with some other lesions. And one of the things that we're seeing in the United States is that a lot of patients, almost all of them, have their initial lesions showing up either in the genital or the buttock area. But another common place in the top left corner, you see that it can show up on the face, specifically in areas where there are beards or mustaches. And that can look a little bit different from what you see. So moving forward into the United States, we first learned about the first case in June of 2024 through a very astute clinician. And he reported that to the public health authorities, and an MMWR was published with more details about the cluster. In the United States, TM7 is not a notifiable condition. So none of the states or local public health authorities have regulations that require providers to report a new infection. And so we're really dependent on learning about what's happening from some really involved clinicians and them chatting with the health departments. And we frequently receive out some knowledge of it through, we have a fungal consult line at the CDC, as well as a fungal outbreak consult line. So as we move forward in time, what we learned from this initial patient is that he had recent travel to Europe and also outside of the New York area in the United States. While he was traveling, he reported multiple sex partners. And as we move forward in time, in 2025, we started to hear about clusters coming out of both Minnesota and Colorado. So how do we kind of move forward with this? And so one of the ways that we've really started to raise a lot of awareness about transmission happening in the United States is through what's called a health alert through the Health Alert Network, which is our way in the United States of kind of blasting out urgent public health information to public health authorities, public health practitioners, local clinicians, and also people who work in the labs. So we've continued to hear a lot more about this, and we really started seeing a lot of these HANs or HANs as they're referred, depending on what part of the country you're at, in early 2026. So Colorado kicked us off with their first HAN about their first reported cases of TM7. That was followed up in February in 2026 in Minnesota. And we really got a lot of coverage that was picked up when these alerts were released. So People Magazine, which is a popular nationwide magazine, caught wind of the outbreak in Minnesota. We also saw another pickup by national media in USA Today. And then the local news stations started picking up as more and more of these HAN notices went out. So in Seattle, King County, in Washington State, the local news was all over it. And so we've continued to have several different states reach out to us with TM7 infections. We have at least 10 who have reported either a confirmed or suspected case in various stages of laboratory diagnosis. And so, we're continuing to see the word, and it's likely that it's happening in more places than where we know about. And so I kind of wanted to highlight and close this off with like, how do we monitor this? Because there aren't a lot of labs in the United States that can do that confirmatory testing where it can be used for clinical decision making and not just research and surveillance purposes. So we have the antimicrobial lab network that is funded through CDC, and that represents several laboratories funded throughout the United States. And we provide funding to jurisdictions at no cost to do that confirmatory testing for TM7. With this data, we're able to track if there are any new areas that have positive results where we may not have heard from those jurisdictions, and we can reach out and do any technical assistance and education. we're able to monitor new diagnoses over time, where they're happening and what's changing. And importantly, these laboratory networks do antifungal susceptibility testing, so we're able to monitor for any potential signs of resistance to terbinafine, which is the primary medication used for TM7. What we've found thus far is that the populations that are most commonly affected by TM7 involve men who have sex with men who report multiple sex partners, people who are living with HIV, people on HIV PrEP, and people with other STI co-infections. And I really want to note and highlight that while we've heard mostly from cases that in the MSM population, anyone can get TM7 if they come into contact with infected skin. And then to close us out, what do we recommend for preventing further transmission in our region? And so the first thing is ideally we would recommend that you avoid any direct skin-to-skin contact, such as intimate or sexual contact involving the impacted area while the lesions are healing. If that's not possible, we want to make sure to cover any of those lesions with a bandage or clothing to prevent unintentional spread. The next is to avoid sharing personal items or clothing like razors, sex toys, or linens. And then finally, to wash clothing and linens on high heat to kill off any remaining fungal spores. And so, with that, I want to give a shout out and a thank you to the many people who have helped with our response thus far within the mycotic diseases branch. Both a lot of members on our epidemiology and laboratory teams have been working on this, as well as our colleagues at the Division of STD Prevention. Again, I'd like to give a shout out to the AR Lab Network and our state and local public health partners who have done a huge amount of work finding out and interviewing these patients so we can learn more. And then finally, to our clinicians who are keeping a close eye and making sure that these patients get the appropriate testing and treatment. So thank you so much.
Thank you so much, Irina. This was a brilliant, brilliant talk and great overview of the situation in the US, but also globally. Thank you for introducing the cases in Europe as well. Let me see. Let's move on directly to Dr. Thuy. Please, the floor is yours. We'll hold the questions for now. I'm going to remind everybody to put them in the Q&A, and we will revisit everything at the end of the four presentations. So, Dr. Thuy, please go ahead.
Well, hello everyone. Let me share my screen. So I was introduced as from Vietnam. I actually lived most of the time at Duke University, and I spent about 3 months out of the year based at the Tropical Medicine Research Center for Talaromycosis in Vietnam. I'm an infectious disease clinician and epidemiologist. And most of my research is in mycology. Can you see my screen?
We can't see it yet.
Okay, hold on.
Mhm.
Okay, stop sharing screen here.
Should we move perhaps to the next speaker and we give you a bit of time
Go
to.
ahead and move forward. I'm sorry about this.
No worries, no
What's
worries.
happening.
Dr. Rossaphorn, are you ready for the presentation? Could you please take over?
Yes, may I share my slide?
Thank you so much. Great.
Yeah, can you see my slide well?
If you may put it in presentation mode, yeah, this is perfect. Thank you so much.
Thank you very much for joining. Let me join in this webinar. Today I will talk about current STI epidemiology in Thailand. Maybe it's not totally related with the T mentagrophytes type 7, but I think that it would be good for all of you to understand about our current STI situation nowadays. So I will talk about the current STI situation and also share you about how we conducted the surveillance, particular gonococcal antimicrobial surveillance, and also the emerging ceftriaxone resistant report from outside countries. So this graph shows you the trend of sexually transmitted infections in Thailand. So you can see that This express incidence as per 100,000 populations and disaggregated by each bacterial STI. And Thailand has observed the rising trend of sexually transmitted infections over the past decade. Approximate 34 per 100,000 population to almost 90 per 100,000 population in 2025. Syphilis showed the most significant increase. Gonorrhea also showed the upward trend since 2022. However, non-gonococcal urethritis, chancroid, and algae they remain at a low level. So this concern is not rising only among adults, but also affecting newborn through congenital syphilis. As shown here, you will see that Thailand has experienced 17-fold increase in congenital syphilis from 74 cases in 2015 to more than 1,200 cases in 2024. So in this slide, I would like to summarize the recent growth pattern of syphilis and gonorrhea. You see that syphilis showed a marked increase with 3.1-fold between 2019 to 2024, with primary driver of the current STI burden. Notably, among young populations aged 15 to 24, increased by 2.7-fold, highlighting significant shift towards younger populations. In contrast, gonorrhea, you will see that gonorrhea has moderately increased compared with syphilis, only 1.5-fold overall and 1.4-fold among youth. However, it is important to interpret this trend in the context of difference in screening capacity between two infections. Syphilis screening is provided free of charge in ANC setting and for people receiving PrEP in my countries. In contrast, gonorrhea screening is generally limited to gram stain for symptomatic patients, and detection remains more challenging, particularly in asymptomatic cases. To address this gap, Global Fund support gonorrhea and chlamydia screening by using gene experts in high-risk population. So now I would like to show you the data from our implementation from October 2021 to November 2025 in Bangkok and surrounding area. So this graph shows you the scale up of screening in high-risk population. Total over 75,000 has been conducted. However, test support limited to only 15,000 tests per year since 2022. As a result, this program has not been able to expand beyond this level despite ongoing demand. The results of the screening show the detection rate. So the overall detection rate is 13.6% for gonorrhea and 15.9% for chlamydia. So these high positivity rates indicate the program is effectively target high-risk population where the burden of asymptomatic infection is substantial. The detection rate of gonorrhea and chlamydia is around 11 to 13% among adults, and it is increasing to 20 to 24% in young adults, and even higher in youth who are under 15 years old. So the co-infection rates rise significantly, reaching almost 1 in 5 among the youngest group. In conclusion, this is the higher detection rate in our younger population, and also support the national data. And then we will move to the surveillance situation for Neisseria gonorrhea antimicrobial resistance. To let you understand how we conducted the surveillance system. And this slide shows you the gonococcal antimicrobial resistance surveillance network in Thailand, coordinated by National Gonococcal AMR Surveillance Center at Bangladesh STI Center, which serves as reference laboratory. So this surveillance conducted through regional STI clinic, and this is supported by internal funding from our government, and we also have another funding which is external funding from WHO. We call this project as EGASP, Enhanced Gonococcal Antimicrobial Surveillance Program. So these structures allow us to early detections of resistance patterns and also support national data and global reporting. So in this slide, show you the result of our surveillance from 2012 to August 2025. You see in bar chart, in bar graph that the black bar graph show you the number of the isolate that we collected in each year. And also the linear graph show you the percentage of Neisseria gonorrhea resistant to ceftriaxone, cefixime, and azithromycin. So we have not seen any cases resistant to those three medications in many years. Until 2016, we found the first case that resistant to azithromycin, and it stayed in the low number of the isolates. Until 2022, we have seen the increasing trend of azithromycin resistance along with the emerging of ceftriaxone and cefixime resistant. And we also sent first to ceftriaxone isolate for whole genome sequencing, and it is found that they were very distant from internationally spreading ceftriaxone resistant FC428 clade. However, in 2025, we found the 8 isolates resistant to ceftriaxone. And for those isolates, we can run PCR for PEN-A60, only the first 5 isolates. And those isolates found positive for PEN-A60, which is globally spreading genetic determinant for ceftriaxone resistance. Not only the report within the countries, but we also found the report outside country from International Health Regulation Coordination Officer. So the first case is in UK that alert us in 2018. So this is the first global case with combined ceftriaxone and high-level azithromycin resistance. And in 2025, that Thailand also found the emerging of ceftriaxone and cefixime resistance. We also have reported and noted from the UK 4 cases that are resistant to ceftriaxone and another one case from Canada. So those 4 cases from UK are heterosexual men who have symptomatic urethritis and came back to UK and found urethral discharge, and those isolates have ceftriaxone resistant strain. For the case that reported in from Canada, so he is also heterosexual man and have symptomatic urethritis, which show ceftriaxone resistance and also high level of azithromycin resistance, and the result of whole genome sequencing found PEN-A60 positive. So this is quite important that the reports from outside the country alert us, and this helped us to strengthen our surveillance program. In conclusions, there is a rising trend of STI in Thailand. Gonorrhea screening in high-risk population remain limited. Antimicrobial resistance for Neisseria gonorrhea is sharply increasing in Thailand, particularly concerning emergence of resistance to cephalosporins. And this is a urgent need for continued surveillance and strengthened antimicrobial stewardship. Thank you very much.
Thank you so much, Dr. Rossaphorn. It was a great presentation and great overview of the situation in the country in terms of STIs. So great, thank you so much. I think now Dr. Thuy is able to present. We can see your screen. Great. Thank you so much. The floor is yours.
Fantastic. Okay. Let's see if I can move it to, I don't know what's going on with my slide today, but you can see my screen. That's great. Let me hide this and display setting.
Thuy, that looks great for my end. We can only see the slides.
Oh, good. Okay. That's
No,
great.
that's
So,
not good. Can you go back to
oh,
what you
this
were
is not
doing?
good. Go back to the other one. All
Yes,
right.
please.
Perfect.
That's good.
So I want to thank Irina, Dr. Kasarskis, and Dr. Rossaphorn for a wonderful talk. I'm going to give a very quick summary with this slide about the phylogenetic relationship with this particular Trichophyton. And as you could see here, basically this branch of starting with zoonothic reservoir ancestry. And then you got initially genotype 3, mentagrophyte genotype 3, 4, 5 in rodent, in rabbit, and farm animal. And then you can see that this branch jumped to human, and that involved very initially the interdigital that infect hair and skin, as you know very well. Genotype 8, now no longer called 8 because it's actually very different. Indothenia is completely different on its own and is highly resistant to benify, as you may have known. It also involved human transmission. And then here you go, TM7 is basically a clade in itself that become highly inflammatory and capable of human-to-human transmission. Moving over here, you could see that there's a zoonotic jump from rabbit to human involving the ITS. A lot of SNP changes here. For example, TM7 have greater than 4,000 SNP changes in the ITS region, and that's why when you sequence this particular part of the genome, you're going to be able to differentiate TM7 from other mentagrophytes and other trichophytons. And this is a fungus, it's a very classic mole. And with whole genome sequencing, they found that TM7 carry multiple, they call metallose protease that able to digest essentially keratin, right? And so it's explain why it's kind of invasive. And you can see in this picture, TM7 is able to invade very deep, deeper than the epidermis. So it doesn't just stay up here. They actually went deeper into the dermis and actually can involve way deeper, causing deep dermal invasion and causing what's called Machki granuloma. So very aggressive inflammatory condition compared to other trichophytons infections. This particular TM7 has also carried some mutation in the squalene gene that have been known to be the gene responsible for antifungal drug resistance. So there's potential for this to develop resistant to antifungal. Right now, we don't see a lot of resistance yet, but potentially because of mutation already been seen in this particular squalene gene. And then the factor that facilitate the global expansion of these infections really involve human sexual network contact. And so for some reason, this particular fungus is able to transmit very efficiently from human to human within intimate sexual contact. And then the other drivers have been, as you can see in the figure that I'm going to show next slide, and already Irina talked about that, is in the beard area, in the face, and probably in the pubic area involving microtrauma from grooming, and then share formite, tau, etc. And then global expansion that, as she's already given you a fantastic talk about. And so some basic thing is that it's involved the groin area and then the facial area in the sexual intimate area of the body. And it doesn't respond very well to topical therapy exactly because of this pathogenesis deep in the dermis level. Therefore, you need systemic antifungal therapy and you actually need to treat longer than usual. Usually with systemic antifungal therapy for these conditions, even with endothenia, we treat for about 2 weeks. But this particular one, you have to treat sometime up to 4 months. So the clinical red flag, and I'm going to focus my talk in the next few minutes on just the diagnosis. So diagnosis really start with just clinical red flag, clinical suspicion. And so this slide, this picture from visual ID diagnosis really kind of outline everything here. When you see a patient with these sort of condition, MSM, new sexual contact, multiple partner, perhaps have history travel, but as we just heard, is no longer, it's basically now sustained transmissions within network locally. And with lesion that appear on kind of atypical anatomic places for Trichophyton ringworm infection in the general pubic, inner thigh, buttocks, and beer area of the face. They're mostly more inflammatory than others, severe, painful, ulcerated lesions, and a lack of response to topical antifungal or lack of response to short course of oral antifungal. The differential diagnosis, as you can see here, it looked just like any other ringworm, but the location is important. Scraby can also be in the differential diagnosis, eczema and psoriasis, for example, and contact dermatitis. And so as you could see, herpes, syphilis is all in the differential diagnosis. And so you could see if clinicians don't know about TM7, for example, for these conditions that is mostly very common, eczema, psoriasis, they're going to give topical steroids, which make a condition worse. So with respect to sample collection, when you've got clinical suspicion, the next thing to do is really to get to the diagnosis, you need to do skin scraping. And this really demonstrates the technique how to do so. First, you need to clean the surface with 70% alcohol to reduce the contamination from the skin, right? If you got bacteria overgrow, you're not going to be able to detect fungus because bacteria divide every 20 minutes versus fungus, right? And this particular fungus take up to, this actually grow quite fast, but it can take up to a few weeks. And then you use a scalpel on active lesions around the border of the lesion. That's where all the organism is, because that's expanding. And then you place on the glass slide, and then you also, the slide is for microscopy and stain, but then you need to use a Q-tip to press on the lesions and put it on the container, sterile container for cultures. You could do punch biopsy for lesions this is the same lesion, but for lesions that appear deep, inflammatory, and nodular, which is unusual, you wanted to rule out other causes and of course these conditions and do a biopsy, which take a deeper skin. And then processing, you need to split sample for pathology and fungal cultures. Direct microscopy, you could do this in the clinics with KOH prep. So most of the dermatology clinic will be equipped with this, and you could really see first just this hyphae, branching hyphae with these conidia, and so doesn't look any different than other Trichophyton. But this is a microscopy under the microscope from a culture, a little bit more characteristic with particular stain here. So again, KOH. You can rapidly confirm whether the lesion is a fungal infection versus some other condition. So that's certainly geared towards few things and easy to do. Like I said, branching hyphae with orthoconidia. Limitation is it doesn't identify specific species as we talk about. In terms of staining, you can use calcophoryl white or lactophenocotton blue if available. That will enhance the hyphae fluorescence and allow you to see much better. This particular Trichophyton 5 has this beautiful shape and under the blue lactophenocotton blue, it's really beautiful. culture isolation can be done in media with the Sapporo alga plate. And as you could see, these are just really beautiful colony when you incubate at room temperature. So anything 30 degrees or less, and up to 4 weeks, you could grow these beautiful colony. And white to cream color, powdery granular colony. And um, and basically, I just show you the previous slide on the under the microscope. You see the hyphae with abundant microchlamydia. But to get to the species, you have to do molecular PCR first and then sequencing, and I'll talk about this. And so gold standard is to amplify ITS regions, and there's a commercial primer to do so. And you can only do this, unfortunately, in public health sort of reference center laboratory. Most commercial laboratories do not do this. Of this region, followed by single DNA sequencing to confirm genotype 7 cluster. And like I said, require public health reference lab turnaround of several day to week, depends on lab backlog and personnel. And so this right here demonstrate why we probably way under diagnose this condition right now, because the cluster require people to worry about it and then connecting with public health, and that's what Tom going to talk about hopefully soon. Antifungal susceptibility testing should be done, mainly, as I mentioned before, due to concerns of terbinafide resistance, etc. And if the patient doesn't respond, you would know what next to treat. And you can use CLSI or UCAS method. And currently, they do terbinafide, itraconazole, other azole medications. And I'm sure there's newer antifungal drugs on the markets that can treat this condition as well, but this is traditionally stay with terbinafide and itraconazole at this stage, probably voriconazole as well. And antifungal susceptibility testing can really help you guys systemic therapy, right, when initial treatment fail, and resistant potential in this squalene epoxidase gene that I mentioned at the very beginning. So I'm going to skip this because I know that Tom probably will talk about public health report and containment. Target treatment first line is terbinafide 250 milligram daily for 4 to 8 weeks. Alternative is oral itraconazole or voriconazole failure, or you suspect of resistance. Clinical care, complete resolution of skin lesion, you really doesn't have a fixed time. It's really a clinical determination of when to stop antifungal therapy. And you need to make sure to monitor liver function test during oral therapy. So in summary, you start with screening, clinical suspicion in MSM network, atypical anatomic lesions and inflammatory lesion. And then tests, you could start right now with KOH and fungal culture. And if it's very severe inflammatory and meet these category, you could start with oral medications, or you could start with topical with very close follow-up. You escalate with notify, even if you just suspicious that they have TM7, and then they can do ITS sequence when you notify public health laboratory, and then treat, as mentioned already. So that's the end of my talk. Thank you very much for your attention, and we'll hand over to Tom.
All good, Tom.
Okay.
Go ahead.
Okay, wonderful. Thank you everyone for having me. It's a great opportunity to speak with you. So I'm going to be speaking a little bit more broadly on public health and communication perspectives, community perspectives on TM7. So as we're thinking about all of the different considerations at the diagnostic level, the public health perspectives, there's a lot of things that we should be keeping in mind here. So not only do we need to be thinking about testing and treatment, we also need to be considering health equity and access to public health services and what it's like actually for community folks, whether that be through policy measures, through education, and to try and address stigma. And I want to make the case that TM7 really does matter beyond dermatology. So, as folks have already mentioned, this is an emerging sexually transmitted fungal infection, but it must intersect with HIV and broader STI and clinical systems on a whole. So, because there's a lack of information, I think for the public and as well as for providers, there's a potential for delayed diagnosis or misdiagnosis for TM7 among key populations, such as men who have sex with men and sex workers, as Irina was talking about earlier today. And as Dr. Lay was mentioning, there's a lot of potential diagnostic and speciation limitations for TM7. And combined with that, just broader gaps in fungal surveillance and preparedness, I think, in the region, but also around the globe. So a lot of my work, well, during my PhD was on Mpox and other STIs, and I think there's a lot of lessons learned we can bring from that. So we should be expecting a little bit of uncertainty as infectious diseases are emerging around the globe. Yes, this has been around for a couple of decades. However, we're really starting to learn a lot more in recent years. Something to note is that delaying or stigmatizing communications about this can absolutely worsen disease spread. Um, and it's important to note that community trust and community-led education efforts are incredibly important. But to do that, we need to be working with communities, right, where it's most heavily affected. So whether that be through transactional sex workers or men who have sex with men in a lot of communities, especially as we're thinking about Pride season, June/ through the summer, when there's going to be a lot of large events, gatherings, however you want to call it, which could potentially be opportunities for TM7 to spread a lot further. And just to say, when we're thinking about key populations on a whole, there's often a lot of other things like poor health outcomes because of lack of access to care. Okay, I'm going to be going kind of fast, so we can leave a few minutes for Q&A. All right, and this might be obvious, but community engagement early matters because if folks are aware of what's going on, it can help identify outbreaks at the source earlier. Peer-to-peer education is incredibly important in all of these situations. Trusted messengers improve engagement. So back to our first talk, yes, a lot of news sources might pick up on something, whether it be ABC News or the Times, which is great, but not everyone really trusts news sources. So it's important to meet people where they're at. And also just to say, community partnerships can combat misinformation that exists, whether it be like health influencers who are trying to do the right thing, but also might be spreading incorrect information. Quick note on stigma and assumptions. So, having a sexually transmitted infection is not a moral issue or a failure of someone because of behavior. Transmission patterns don't necessarily define someone's identity, and assumptions about someone, how they appear, could delay diagnosis, right? So, if you're making assumptions based on how someone looks and you're deciding that they don't need PrEP or they don't need to get tested for TM7, that only makes things worse. And this might be obvious, but language choices obviously influence public health responses and just awareness from the public. A few just quick tips when communicating risk in public communication. It's important to acknowledge uncertainty, right? We acknowledge that this is an evolving situation and the science will be evolving. And it's important to communicate that. We need to avoid sensationalizing things. Basically, just saying that this isn't going to be the worst, infectious disease outbreak in the world, but also acknowledging that there is risk for this to, evolve into a much bigger situation. And again, just using non-stigmatizing language is important. I'm gonna skip this since it's a little bit repetitive. Let's see. To do some of this, I do want to say this was touched on a little bit, but framing this as an issue for everyone or saying we and us potentially in some of the languages you're talking about it, rather than saying these folks or this community. It's a little bit of nuance, but I'm happy to workshop some language with folks after to promote dignity, agency, and care seeking among individuals. And this was touched on a little bit, but because there are no vaccines for TM7, right, we need to rely on behavioral strategies and recommendations. And telling people not to have sex doesn't work. So it's important to recognize that harm reduction is key, and whether that be avoiding sharing linens, for example, and all of the other recommendations that were already discussed by CDC. And just a couple of key messages and takeaways for collaborations. Improving provider awareness and education is a great first step. Meeting the public where they're at to educate is a great first step through engaging communities. Um, Reducing stigma through thoughtful communications, balancing urgency with accuracy, and connecting with all of us and leaders who have been working on TM7 for continued engagement, especially if you're anticipating something in your region or country. Kind of trying to tie this all together. So TM7 has been identified across multiple countries throughout the globe. Emerging infections challenge our surveillance systems, especially for limited diagnostic capacity for fungal infections. Disparities already exists among key populations, and these can already amplify like emerging infectious disease outbreaks even further. But we do have the opportunity for collaborations early on, and I'm going to say this is early on, to help shape and mitigate potential epidemics in the future. And I always like to say like something like this, but like, please be kind to each other, stay curious, ask questions to us, to each other, stay informed. Thank you for coming to this webinar, and expect evolving evidence as we learn more about this situation. Of course, thank you to Duke-NUS, Duke Global Health Institute, and the CFAR, Center for AIDS Research, who have supporting me along this journey. And not to like self-promote, but please reach out to my email. And you'll probably get contact information from everyone after the call, but thank you. All right.
Thank you so much, Tom, and thank you so much, Dr. Thuy, for the presentation on the diagnostics and also treatment. I think it was brilliant to see a very great overview. And thanks, Tom, for the call for action and for thanking us. I see maybe we can stop sharing a screen. Yeah, that would be great, and we can see each other properly. There's actually a question in the Q&A, and I think it's better if Dr. Thuy responds to it. It's about how we can really diagnose TM7, considering the differential diagnosis and the lack of, I think, awareness also from clinicians. So it's a very long question. I'm not sure if I should be reading it, but if you want me to read it, I can. Otherwise, please go ahead, Dr. Thuy.
Yeah, so I think this is a challenge because of the requirement for PCR and sequencing. It is challenging. I think from a clinical standpoint, just if you suspect a patient having this TM7, one thing that we discuss is to ensure that we make the diagnosis by starting with just simple microscopy and culture. And then follow these patients, because knowing if you're suspicious that they have it, knowing that the treatment will be different, like oral medication for longer time. And therefore, that's important. From the public health perspective, we really need to understand this disease more clearly. There's a clear signal that this is a sustained human-to-human transmission in all those very intimate sexual network at the moment. But this particular organism is able to really adapt, as you could see. And so you're looking at evolution as we speak of a pathogen evolving, jumping species, and now able to adapt to human transmission, like that of Canada, very much like Canada auris, hopefully not. But if it become Canada auris and multi-drug resistant, then that's worrisome. So I think that we need to get ahead of the game by mobilizing public health awareness and connect with the laboratory that are able to make the diagnosis. Do send fungal culture, anti-fungal susceptibility testing. I know this is hard because we don't even have a mycology reference center anywhere in Asia except for Australia, right? And so I think this is why we have this webinar to really kind of raise awareness, and laboratory like research laboratory across Southeast Asia will be able to help with this. For example, the TMRC where we can do the sequence and if there's need. Oxford University Clinical Research Unit in Vietnam, Singapore Genome. So all of these places can probably join force and help with this if it's become a much bigger issue.
Thank you for that. I think awareness, I agree, awareness is the most important thing. And then really training the clinicians to identify, not necessarily with only molecular testing, but also understanding the morphology, no? If they would have been able to understand the difference morphologically, that probably would already help. Being a virologist, I don't understand fungi enough, but it seems to me that the first step would be awareness indeed. And maybe I can bridge to Dr. Rossaphorn actually, because there was a question from Tom in the chat, but I think you sent it privately, but I'm going to throw it in there. I think it's important. Do you think, Dr. Rossaphorn, that your current surveillance system, STI surveillance system that you have in the country, would be able to pick up something like this? Are you prepared to at least have a suspicion of having the species?
Actually, I have discussed with our colleagues that also dermatologists and non-dermatologists that work in STI clinics to see that how did they detect anything for that look like tinea curis or tinea corporis in those MSM. Yeah, and suspected on that like an outbreak. Actually, they said no. This is quite strange, yeah, for us. Yeah, but if we would like to do the surveillance for the fungal mentagrophytes TMVII in Thailand, we could integrate this to our gonococcal antimicrobial surveillance system. Yeah, but not for the screening program. As a screening program, we use PCR, so they can do the cell swab. So if patient do not inform the doctor that they have lesions. But if those lesions are painful, it probably that they will request or asking for some treatment to doctor if they reach to the clinic. So yeah, so for now, we do not see anything spike, yeah, for the fungal infection, but this seminar is quite good for us to be aware of that, and also we will looking for to the strengthened our fungal culture system in Thailand. Yes. Mhm.
Thank you so much. I will ask Tom and Irina if they want to add anything before we close the session. We are 2 minutes over. I understand we might have to close soon. Anything to add or any questions?
Irina, do you want to chime in?
I think it's really been interesting to hear what is happening over with our colleagues in Asia about challenges with TM7 diagnosis. So I really appreciate learning from you and hearing that we're not different with some diagnostic challenges for identifying TM7. And I think our partnership moving forward will be really important to make sure that we're able to treat these infections appropriately and hopefully avoid further antifungal resistance.
Yeah, echoing everyone's comments, I think that we still have a huge potential to shape and mitigate potential epidemics and outbreaks of TM7. And I think that with our partnerships, and I see a lot of folks on the call from everywhere from Sri Lanka to Pakistan, that we have the ability to work together on these really complex challenges. So just thank you for the Asia Pathogen and Genomics Institute and Duke-NUS for having this webinar. This has been incredibly helpful for me as well. So thank you.
Thanks, Tom. And I think I would just like to say that please, everybody online, please do not hesitate to reach out, email us or email any of the panelists. We're always happy to help and understand that really there's an issue of awareness, but then also capacity for diagnostics. Molecular tests are really an issue, and since this particular fungal infection needs molecular diagnostics, that can be quite challenging. So that being said, please reach out. We're happy to help, and the idea is to create a community and help each other as much as possible, especially in this kind of circumstances. So with that, I will close the session and thank you all for being here and presenting today. And I look forward to more webinars.
Thank you, everyone.
Thank you.
Have a good night, good day.
Thank you.